My name's Steve Ferrucci. I work at a VA hospital out here, and I have the EIDON by CENTERVUE. And right now I'm in my office in Porter Ranch, California. And I'm going to chat with my friend John Warren, who's at his office, his home office in Wisconsin. And he's going to talk about how he uses the technology in his practice. So John, if I'm correct, you have the newest unit that CENTERVUE has, the DRSplus. Is that correct?
We started using it, I want to say late January. The box showed up, and it was kind of interesting. I actually timed it. It took us 13 minutes from cutting the box open to taking the first image to set this thing up, including putting it on the wired network. And because we'd been using the Compass before, which is also a CENTERVUE product, we're somewhat used to the workflow and how to figure out how to put a patient in and do things. So it's pretty easy to do that. And we were going to have some training before all of this happened, but we're actually self-trained on the device. So what we did with it is we just started imaging every patient that came in the office that wasn't coming in to pick up glasses or have an adjustment. If they were going to be seeing me, we imaged them all because we wanted to see, who could we and who could we not get good non-mydriatic images on. And in my practice, I've got in a private practice setting, but 80% of my patients are over 40 and 60% are over 60. So it's a lot of older, sick eyes. And I've taken over a refractive surgeon's practice. So I have tons of post-LASIK, post-RK, post-ALK. You probably remember some of those days. And post-RK patients. So we're looking through all kinds of corneas, lots of older patients. We were shocked with our ability to image patients non-mydriatically with this device. I've got a Topcon Maestro that I use as my OCT, and I've been doing fundus imaging with it also. And we've actually stopped running the fundus image portion on the Maestro for the most part. We use it a ton as an OCT. It's a great OCT, but it's actually changed the way that we image, do the fundus imaging on those patients. So that's kind of how we got going with the DRSplus, but it's been a really neat addition to the practice for imaging patients. So in my practice, I've got the DRSplus, the Compass, which does fields and does confocal imaging of the fundus optic nerve and the posterior pole. And then I've got a Daytona Plus, and I've got the Maestro. So I've got lots of different ways to image patients and capture stuff. So I've actually gotten to the point where it's not that common for me to actually look in the eye myself unless the patient doesn't opt for the optomap. In that case, then we dilate the patient and do a traditional peripheral retinal exam. So it's actually in a significant way changed the way I practice because of the quality of the fundus images.
John, can you talk a little bit about, I think you did a little bit about how easy it is to use it in your practice? You talked about it a little bit.
Yeah, we found that less than 1% of the patients couldn't be imaged with it. These are patients that were old enough to understand directions and that sort of thing. There's some patients you just can't use certain tools on because of the cognitive issues or age. A couple of very old patients that had neck issues, they just couldn't get positioned at the device. But we're able to pretty much image everyone, at least the central fundus, about a 40-degree image on just about every patient. If we can't get an image on them, I'm probably not even going to be able to see through a dilated pupil, see much in the back of the eye. Why don't I show you an example of this? This was actually a patient, a 60-year-old guy who presented for a routine exam. This is an example of a non-mydriatic photo with the CENTERVUE, pretty much an average typical image that we get. And this is a patient that did opt in to having the optomap done on him. But when you take a look at this, everything looks pretty normal in the posterior pole, maybe some slight vessel tortuosity, but nothing that really jumps out. But when we put him on the optomap, you can see right down here, we've got a small hemorrhage, a little blot hemorrhage that on the surface of the hemorrhage doesn't concern me too much about the ocular health, but his systemic health. So we then brought him back to the DRSplus, and we ran a montage on him so we could actually get a high resolution image of that hemorrhage so I can follow it over time. So it was an example of the two imaging technologies actually playing together very well. With the optomap finding something and then the DRSplus being used to actually follow it in imaging too. One of the other things this does is it actually does anterior segment imaging too, without any additional add-ons as far as, dropping an extender on to increase the working distance or anything. You basically pick what image you want to take, whether it's any one of the internals or the external, and the camera adjusts itself, locks onto the eye, and takes the image. This is actually a hyphema in a patient. You can just kind of see the layering of the hyphema here on the image, but it's actually a pretty darn good anterior segment image that you get. So, the device, you basically set the patient down and you can see if their eye is in pretty much the right position. You hit start and go from there.
Those are great images,
yeah,
especially the anterior seg. I'm very impressed with that anterior seg picture.
Yeah, I talked about the not using the Maestro anymore. This is a patient. This is the same eye, same day, same pupil. This is the image that we got with the DRSplus, and this is the image that we got on the Maestro same day. Those are the exact same patient, same pupil size. He wasn't dilated for one, not for the other, but it's just stunning the images that you get with this thing. So it's pretty interesting to see what you can do with this device to capture images on patients. We actually now, every patient that comes in for an anterior segment eval, a posterior segment eval, or a complete exam, we're imaging them before I see the patient. I've actually changed my flow around a little bit. We image these patients, and then my staff does acuities, and then I go talk to the patient, kind of refine the history a bit, do the slit lamp exam, and then move on with the rest of the exam with my staff. And we found even with most patients, unless their contacts are drying on the eye, we get great images right through contact lenses, soft lenses, gas perms, really not bothered by this. So it's been interesting. I mean, I think in your setting, it might be interesting to see these kind of images on the 72-year-old that comes in for a cataract follow-up, to be able to rule in or rule out any pathology in the posterior pole before you have to worry about what else is going on.
Yeah, no, that's a good point.
Use the EIDON, right? And that's a technology I've seen at trade shows but haven't used myself. How do you utilize that clinically? In
my practice, I have the EIDON, and my practice flow is probably a little bit different than many people's in private practice, in that I dilate a huge majority of my patients. And it's interesting, one thing I think that you said was interesting is that, you really don't look in the back of the eye anymore. And I would say I probably still do look in the eye. I think there is some value there. But, if you asked me a couple of years ago, I would have said, well, the cameras are just good for documenting what you see. But now, especially with the EIDON and what I've seen with the DRSplus, because of the great resolution, I think it's a great adjunct to your clinical exam. And very often I would argue that I do see things on the photo that I don't see on clinical exam.
Isn't it crazy the ERMs that you see?
Oh, it really is. Or even just, subtle changes in the diabetic, some ERMAs, and I encourage my residents to take pictures as often as, in a perfect world, I'd take a picture on all diabetics, but unfortunately, sometimes we get a little too busy and we just can't do it. But I encourage them to take pictures and look at the picture, because you have a patient, they've got a little bit of a cataract, like you said, or they're not holding still and you want to look. And sometimes it's very hard to get a good fundus exam to see, are there ERMAs, are there hemorrhages, and what have you. But now you're taking a nice high quality still photo, and if you look at that photo, sometimes I'll see stuff in that photo that I missed on clinical exam. So what I sometimes like to do, it doesn't always work, but in a perfect world, what I would do is kind of what you said: take a photo, look at the photo before you look at the patient, kind of look at it and say, okay, there's something in this area I want to have better look at on clinical exam. What's this over here? And then really look at that patient so you can see what is going on. So, that's kind of how I use it. I use it more as an adjunct to my retinal exam, not only, not to surpass it, but to kind of adjunct it. But I understand your point completely. A retinal specialist that I used to work with once told me,
about is just the ability to see more of things at the same time. Versus the field of view you've got with a 90 or a digital wide field or whatever it may be. Seeing everything in relation to other structures. Yeah,
no, I agree 100%. And let me, ease of use, you went through that. I mean, it's so easy to use, and those people aren't familiar with it. It auto focuses, it auto places itself. So really the amount of time that the technician has to spend there is relatively limited, quite frankly. And it's great. And we dilate the majority of our patients, but as you mentioned, even with a relatively small pupil, you can still get very, very good images.
Yep. Yeah, I'm curious to see the kind of not so much how the images compare as far as clarity, but the montages and things.
Yeah. So one thing that is becoming increasingly evident is that when I was in school, and John and I are about the same age. I'm a little better looking, but we're about the same age. But when I was in school, they said, diabetes, it's really in the posterior pole. And a lot of the newer evidence is showing that you really have to look in the periphery now. So things like this that help us look better in the periphery and document what we're seeing in the periphery, I think are really important moving forward. And some of the newer studies are saying we miss about 30% of hemorrhages, 27% of ERMAs, and 34% of NVE outside of the standard ETRS fields, which a lot of standard cameras don't even go out that far. So if we're not looking in the periphery, we're really going to start miscalculating the level of diabetic retinopathy in diabetic patients. And I have a very large diabetic practice at the VA. So to me, that's very, very important. And this is just an example, of a kind of a montage patient, a patient with moderate to severe non-proliferative diabetic retinopathy with the EIDON, in the montage. And you can see what good quality we have. And over sort of to the left of the optic nerve, you can see a little bit area of probably IRMA. And then this is that same patient taken with a traditional retinal camera. So you can see how much more you can see and how much better you can evaluate their level of retinopathy. Same thing here. Again, this is a patient with the EIDON on the montage, and here it is with just a standard retinal camera.
And I'm guessing that's about a 20/30 cataract or worse you're looking through with the EIDON.
Probably.
Wow.
Yeah, I've got you an image in a second. I'll show you something that's kind of interesting. But here's another patient with mild NPDR, and this is just kind of three photos put together in a montage. And again, rather than just getting the central field, you get a much improved and wide view here. Another patient with mild. And again, we can see all these peripheral hemorrhages that if we were just looking in the posterior pole, we would probably miss on this patient and miscalculate them. Here's an example of a patient with moderate to severe non-proliferative diabetic retinopathy. And here you can see a lot of hemorrhages, in all four quadrants. And we can remember the 4-2-1 rule back from our days in school to help remind us, the importance of looking for these things in our diabetic patients. Here's another patient with a lot of hemorrhages in all four quadrants. And again, you can just look at the quality and how you can see these ERMAs and these mild changes that maybe you can't see on clinical exam. And here's a patient with severe NPDR, maybe PDR, because this looks certainly like some area of neovascularization here that is of concern. Again, another patient with severe non-proliferative diabetic retinopathy, and you can see some venous beading here as well as hemorrhages in all four quadrants. And it really helps us take better care of our patients, because based on some of the newer information out there, it's important to start thinking about treating these patients a little bit sooner when they get to the level of severe non-proliferative diabetic retinopathy than waiting, longer. So I think it's really important. Here's an example of a patient with proliferative diabetic retinopathy in the left eye, and there you can see a nice example of some neovascularization. Whoops, a nice example up there of some neovascularization. So really, beautiful images. And again, perhaps if the patient has some cataract, they're not the most cooperative patient, you could imagine you could miss that tuft of neovascularization. But when you look at the picture and you can sit there and examine it for a couple minutes without the patient, it's much more evident in this case. And this is an example of a patient who's had a lot of PRP, and you can see they have a lot of scars. Macular degeneration, I love to take it to help, monitor these patients along with an OCT to look for drusen and changes. And here's an example of a stage 2. Here's a little stage 3, a little worsening. And here's a patient with an atrophic scar. And here's a patient with wet AMD with an obvious hemorrhage. So the images are high quality, really, really good to help you monitor the patients. You were talking about media opacities, and what I found was, I do have an older population, a lot of cataracts and corneal issues. And the EIDON, because it doesn't use only traditional white light, it also uses a scanning laser ophthalmoscope, that you can really penetrate these medial passages to get much better images. And on the left-hand side, this is from the traditional camera, and you can see not a great image. And with the EIDON, you can see how much better that image is, and you can really see what's going on with that patient. And same patient, here's his left eye. And again, you can see how much clearer the image is with the EIDON versus the traditional camera. And there's an example of a patient, you don't run into this all the time, but a patient with asteroid. And again, you can see with the traditional camera, you really can't get a good view at all of the fundus. But with the EIDON, it's able to penetrate that opacity, and you can really get a pretty usable image. So certainly in these patients with cataracts or what have you, it's very, very helpful.
Yeah, the DRSplus is the same way with the asteroid and the significant floaters that you just can't see around or through. It's amazing how it's not bothered by those issues.
Yeah, no, I agree with you. And it's been, and sometimes it's the only view you're going to get sometimes. So it's really, really important. I just want to just close real quick, just show you a couple examples of some pathology that I see. And, this is, more of some pathology, not so much for screening, but to document some pathology. But nice, BRVO here. This is kind of in the one-shot center field. And then this is kind of in a wider field. And this is in the whole kind of mosaic. So again, you get a really good feel for what's going on in the retina. Here's another patient with a BRVO, a couple different ways, a couple CRVOs, and again, you really get a nice feel for what's going on in the retina. Hollenhorst plaques, we see a fair amount of those in our patients, and you can see a couple examples of those. Unfortunately, a patient with retinitis pigmentosa, nice example there. A patient that I saw with bilateral choroidal metastasis. This story did not end well, unfortunately. But again, you can really get a beautiful view of the retina here. And then is an example of a patient I saw with in the left eye with two retinoschisis. You can see one superior, one inferior, and there they are on close-up. And the interesting thing about this patient, I saw the retinoschisis in the left eye. I thought his right eye was fine, but when I actually took the EIDON of the right eye, I think you can appreciate up in the superior temporal area, there's actually a little retinoschisis there as well. So again, I used to think that these here's another schisis as well. And we're able to show over time, over 6 months, side by side, first visit to 6 months follow-up, that this patient's stable. So it really gives you, makes you feel a lot better that you're taking good care of this patient. So like I said, I used to think that the cameras were only good for sort of, documenting what we see, but really with the quality being as good as it is, I really think it adds to, or in some cases, as you mentioned, John, might take place of our clinical exam. So, and I'm going to kick this back over to you, John. What I'd like you to do, can you tell us a little bit about the compass? I think probably a lot of, I'm not all that familiar with it, and some of our people might be watching might not be.
What are you using for fields?
Unfortunately, a Humphrey.